So in the next couple of minutes, we will discuss the anti-CD19 antibodies. And I find the whole story fascinating because we always knew about CD19 there, right? It was before CD20 by the number, but CD20 therapies were first. And for a long time, there was relatively slow progress in developing CD19 antibodies or targeted therapies. Now we actually see that this is a major target, which really is not only important for CAR T cells and cellular therapies, but also for monoclonal antibodies, antibody drug conjugates, as you will see. And also there's a whole bunch of bispecific or trispecific antibodies now targeting CD19 as well. So it really shows the importance of this pan-B-cell marker as a therapeutic target. And the one of those antibodies, monoclonal antibodies developed against CD19 was tafasitamab. It was really engineered to increase ADCC and the binding to CD19. Now, the antibody as a monotherapy showed the response rates in about 20 to 25% of the patients in aggressive lymphoma. And it was quickly postulated that really a synergy with IMiDs, particularly lenalidomide here, could increase its activity through the activation of immune system. And we just had this great discussion about golcademide and the next generation of CELMoDs in this space. Golcademide studies in combination with tafasitamab are ongoing. But at that time, lenalidomide was really the main standard of therapy in terms of the increasing activity of the antibodies. So lenalidomide was combining with tafasitamab in this landmark study called ELMIND, conducted by Gilles and his colleagues, where lenalidomide was taken with a schedule of 25 milligrams day 1 through 21, so the dose which is typically used in myeloma, a little bit higher than we use with R-square, with tafasitamab on a schedule seen here. The initial patients were treated with the combination, and then after 12 cycles of therapy, there was an option of remaining on tafasitamab alone, and patients who had benefit from therapy, so had no progression of the disease. In retrospect, a lot of questions about this when the study was published with the results, why this extension of the therapy was included in this trial. However, if you think about the landscape when the study was developed, the options for those patients were extremely limited. And most of the investigators participating in the study felt that they really want to have this option of continuation of therapy for the patients who benefit from this therapy. And the other inclusion criteria were patients basically had to have at least one, but no more than 3 prior regimens of therapy, and being not eligible for high-dose chemotherapy or stem cell transplant. And those are top level results from the study. So you can see that overall response rate in the study was approaching 60%, which at the time when the study was published, with the targeted therapies was essentially unprecedented in this space. What was interesting in a subsequent analysis that in a second-line therapy, so patients who only received one prior line of therapy, the response rate appears to be a little bit higher than in the patients treated with later lines of therapy. The other question was, of course, about durability of the responses with this combination. And as you can see here in those progression-free survival curves, there was evidence of excellent durability of the response. And it's not only reflected by this median PFS here, but also if you look, there's about 40% of the patients who are basically disease-free at about 3 years. So the subset of patients who have the response, particularly deep response, tend to have a very durable responses with this regimen. So this data really led to accelerated approval of combination of tafasitamab and lenalidomide in relapsed refractory aggressive B-cell lymphomas. Of course, when such a treatment is developed, people wonder how it performs in the real world. And I think we have a large number actually of real world studies and different comparisons of this regimen to existing therapies in this setting. There were studies called REMIND, where there was a propensity score matching against different covariates of this therapy to other treatments. But there were also real world data. And this one published by Derek Wells first, was looking at patients treated in real world with Tafa-Len. And what was interesting about this study is that in general, if you look at the performance of this regimen, it was worse than seen in L-MIND study, but it was worse in the patients who didn't meet the inclusion criteria for L-MIND. If you actually did meet inclusion criteria for L-MIND, just like in a study, the results were better. And we see it frequently with other agents as well. That's a little bit more recent study showing, again, real-world effectiveness in U.S. centers where the number of patients who were actually compared and studied where patients were actually meeting criteria for L-MIND study. You can see the patient flow and characteristics here. And overall response rate was comparable to what we had seen in L-MIND study. Maybe CR rate was a little bit lower, but overall response rate was actually a little bit higher. And the similar trend, which we've seen in L-MIND study, that patients treated in a second line or had less lines of therapies tend to respond better than patients which are more heavily pretreated in this setting. The other interesting question, of course, about CD19 therapy is because we have so many agents targeting CD19, is the persistence of CD19. And that's particularly important because if Tafa-Len combination or tafasitamab is used in the first line or lines before the CAR T cells, for example, can it affect the expression of CD19? This is from the work presented at ASH last year, which is looking at immunohistochemistry and also expression by gene expression profiling and all in sequencing of CD19. And those are the patients who are either exposed to tafasitamab on the study or in the real world. And what's interesting about the study that CD19 expression by immunohistochemistry appears to be preserved, even in the patients who are relatively recently exposed to tafasitamab. And there was some very nice preclinical rationale for this, how quickly the receptor turnover occurs on the surface of the cells. There's also an interest in responses to CAR T cell therapies in this setting. The data is really anecdotal, related in relatively few patients, but at least in this study, it appears that CAR T cells can be successfully used after exposure to tafasitamab. Indeed, there are actually some studies ongoing which are actually using pretreatment with tafasitamab prior to CAR T cells, and the idea is that modulation of CD19 expression actually reduces overactivation of CAR T cells and early apoptosis related to overactivation. So expansion actually could be better. So, those studies are showing there are good examples that the sequencing of CD19 is possible, and we still have to study and learn about what's the best sequence. But the receptor appears to be abundant, and they're circulating very quickly to the cell surface. Of course, with such an active combination of Tafa-Len, tafasitamab, lenalidomide in relapsed refractory setting, there was an interest in moving it to frontline setting as well. And here we're in a good position because there were actually 2 studies available of lenalidomide in addition to R-CHOP. So some of the work had been done earlier, and one of them we're familiar with is robust. This was a study designed for ABC patients only, using lower dose of lenalidomide, and this one did not show a difference with addition of lenalidomide to R-CHOP. There was another U.S. intergroup study called E1412. This study was using higher dose of lenalidomide of 25 milligrams, day 1 through 10, just assisted use in combination with tafasitamab and lenalidomide in the relapsed refractory setting. And this study actually was randomized phase 2, showed a potential signal of a benefit of adding lenalidomide to R-CHOP, but definitely has shown that lenalidomide can be added in a safe and potentially more effective fashion. So this has led to this first MIND study, which really looked at addition of tafasitamab only versus doublet, tafasitamab and lenalidomide, using this E1412 schedule, so lenalidomide day 1 through 25. And this is a good example of this Project Optimus and dose optimization, because this phase 1b with the doublet versus single agent allow us to understand the potential feasibility of this combination and potential dose delays of chemotherapy and potential efficacy. And in this small randomized phase 1b study, the totality of evidence was supporting doublet. So there were no significant dose delays with the doublet, but the early efficacy appeared to be superior in a doublet versus adding the monoclonal antibody alone. So this has led to this currently ongoing, actually completed accrual, study which completed accrual. We're expecting hopefully results very soon on this study called the Frontmind. And there are some interesting elements of the design of this study. Number one, it compares this doublet on the top of R-CHOP backbone to R-CHOP alone. And number two, if you look at the patient inclusion criteria, was really focusing on patients with the high-risk disease. So high IPI, 3 to 5, and also time from diagnosis to treatment less than 28 days. So it was previously seen in robust and E1412, and a lot of patients in the robust study had a delay entry to the study due to requirement of molecular subtyping. And here the focus was to capture those patients who rapidly progress and really cannot wait because of this rapidly progressive disease with the high IPI. So this study is maturing, and hopefully we're going to see the results of the study soon with this doublet versus R-CHOP therapy. Just to, for completeness, the other antibody or antibody drug conjugates, which target CD19, is loncastuximab tacitidine. Tacitidine is a DNA cross-linking agent. And as a single agent, this antibody is active in a relapsed refractory large cell lymphoma. In a third-line treatment, as you can see here. The response rate is approaching 50%. About half of the patients actually achieve CR. And what's interesting about the study, that at the time the study was conducted, there were also patients now relapsing after CAR T cells, and the responses are also seen in post-CAR T cell relapse. And that's again points towards this sequencing of CD19. It's possible, even after CAR T cell relapse, and those CD19 therapies can be still active in this setting. This has led to subsequent studies. The phase 3 study is LOTIS-5, which compares lonca with rituximab versus R-GemOx in the relapsed refractory setting. I understand this is registrational study for lonca. And loncastuximab also is an important backbone for other combinations, particularly CD20 targeting bispecific antibodies are looking very interesting and very feasible to combine in this setting. And there are many more investigator-initiated studies trying to investigate lonca in different combinations. So I think we have a couple of discussion points here. First, what's your take on the activity of tafasitamab and lenalidomide, and how do you currently use it in a clinical practice? Because a lot have changed since Gilles published the initial study. So how does it currently fit your practice? And maybe we'll start from this question. Sonali?
Yeah. So, I think that at least in the United States, in the Midwest, this has become, I think, an appealing option for second-line treatment of DLBCL, particularly for patients who don't have access to CAR T or even to bispecifics. And this may be changing over time, but I do see uptake in that setting. One point I might just make on a practical level is that the lenalidomide dosing, and you already raised this, is a little bit higher than what we typically use. And I think that this may be one of those analogies, like when bendamustine was first approved, the dose was much higher than the 90 milligrams we use when it's with rituximab. And it may be something similar with the Tafa-Len regimen, that going forward, a lower dose is going to be used. And certainly I see a lot of dose reductions in people who are receiving this in the community.
Yeah, I would agree with it, because a lot of folks who have renal dysfunction, additional reasons, frequently the cytopenic starting lenalidomide as well. One of the problems also which I see in the community sometimes, and I'm trying to always address it, that you really need two to tango. Tafasitamab by itself doesn't work so well. You really need to combine it with lenalidomide, and sometimes lenalidomide arrival is somewhat delayed, and people sometimes tend to wait for the next cycle. I usually tell people, don't wait. The minute it arrives, just start the combo, because you really need two for this efficacy, which was initially seen in the study. Ulrich?
Yes, I'd like to follow up on this topic of second line. So I think the real value also in the 5-year update was for those patients who relapsed after 12 months, right? And that's the population where we sometimes have problems to prescribe CARs for administrative reasons, for instance. So I think the results are good. This is a population where it really could, which could really benefit. The competitor there would be the Starglow, of course. But I think this is a good option for this particular subset of patients.
That's a great point, because they are frequently not eligible to cellular therapies, as you pointed out, and the results were indeed very good in those patients. Great point. I think you're...
Yeah. Sorry, I was muted. I think the point made by Sonny regarding the dose of Len is very important. I think I have never started this regimen in real life at 25. I usually start at 20. And I do know a few patients that started at 10 and benefited for 1 year of this regimen. So I think there is here something that probably needs to be, further investigated or known. I think, when we were a little bit surprised and disappointed when we performed the study with David and many other of you when we collected this data, this has clearly the fact that this population of patients in the trial at that time was probably a little bit more frequent, but now becomes rare, and probably also the effect of referral to tertiary centers or more difficult to treat patients. And the same way, the other data that are presented at ASH are a little bit biased by the fact that these patients were basically having already 4 months of treatment with the drug. So basically, all the early failures are out of this result. But again, what it shows is that there is a group of patients that respond very well, get into CR, and can benefit for a long time. So questions that remains unanswered to me are twofold. One is, how long do we need to administer Tafa? And, maybe now we are a little bit out of COVID, but I think I have one patient that died from COVID while receiving this regimen in real life. And, she may have died, whatever, but, at some point you want to stop B-cell depleting agent in patients. I mean, CAR-T sometimes have prolonged effect, but if after 1 year of Tafa, can we stop it or not? And I think that's a question for the all drugs developed as indefinite treatment in DLBCL. The second question is a little bit the fact that while I haven't clearly got a clear answer, the PK data supporting the weekly administration during the first 3 cycles, and after that every 2 cycles, this is a little bit kind of longer constraints for patients. And I think patients have to come every week to the clinic and get the infusion. And I think we need, to have a little bit better understanding what is needed here in DLBCL and also for development of this drug in FL.
Yeah, that's a great point. I think since then, there's some additional optimization studies being run. I haven't seen the results yet, which is trying to evaluate different schedule of tafasitamab, because you're right, the PK rationale for initial schedule was somewhat soft, was kind of the best choice, I guess, at that time. Sometimes you don't argue success because combination was active, but it's clearly bringing some additional burden to the patients, and the additional schedules were evaluated. So I'm eagerly looking forward to those results, because it will definitely make it easier for the patients, particularly the ones which Sonny mentioned, which are coming from longer distances in Midwest, that are getting in local practices, or the travel is an issue. Can you actually minimize the burden and return less frequently? The duration of therapy is also very interesting topic. That's why I mentioned that when initially study was designed, it was a little bit, the decision was made to continue in some of those patients. Back then, the MRD was somewhat more limited. I think nowadays we probably could design better studies with MRD to really guide what's the ideal duration of this therapy. And we also have to get some real-world evidence how well the retreatment works. Anecdotally, I had some patients actually who did experience progression, sometimes after a very prolonged time, and then retreatment did work. They wanted to try it again, but that's very anecdotal. We don't really know what's the retreatment response rate like in this setting. How do you, any additional considerations when you're choosing anti-CD19 therapy? I mean, is there thinking that the CAR T-cell therapies could be available at some point for those patients if the performance status or ability improves, affecting your thinking about using it? Catherine?
I think that with this tafasitamab, one of the important questions is what about sequencing therapies? So if we improve the performance status, for example, of the patients to go to CAR-T, how will we fit all these treatments together? And I think this is a key point. You showed nicely that the expressions post-CAR-T cells may still be strong and positive for these patients. But I think that when we are choosing the sequencing treatments, we have always these questions in the head. Are we sure that we will not impair CAR-T cell treatment after tafasitamab? I don't know if you have some experiences for these patients and this sequence of treatments.
Well, our experience was limited to the preclinical work done by Satkandarian at Mayo, who basically showed in animal models and preclinical models that this exposure to tafasitamab potentially could be even favorable to CAR T cell expansion later on. And the clinical experiment with kind of bridging and time therapy before the CAR T cells is ongoing. So I have to wait for those results if indeed it's going to affect the ability or efficacy of CAR T cells later on. I'm actually somewhat encouraged by this work, which shows that CD19 expression is preserved. And the other thing, what our translational colleagues are always telling me, that there's plenty of CD19 there to go around for CAR T cells. So apparently, you don't need to have all those molecules engaged to actually see the efficacy of CAR T cells. So those are some of the preclinical data, which appears to be somewhat reassuring. But yeah, you're absolutely right. We'll have to wait for the clinical experiment. And that's particularly important because we also look at this frontline study in the setting as well, right? So presumptively, some of the patients who are absent frontline would proceed then to CAR T cells or other therapies. So understanding what will happen to those patients will be very important.
I hate to say it, but the treatment of lymphoma is becoming more and more fragmented as we see these different regimens come out. And I don't want lymphoma to become like myeloma in terms of all of the choices and all of the different pathways that patients can take. But having a choice for a CD19 antibody-directed treatment, and we don't have the same choices in Australia as you have in the US, but having that choice is increasingly important as we see bispecific antibodies come into treatment regimens with the recent availability of Starglow. It will learn more about CD20 loss as a challenge in terms of sequential treatments. And so I think the way we use these antibodies will very much depend upon, how what the patient's immediate prior therapy was, and more having choices that don't target CD20 might be important, I think, as we see these bispecifics come into practice.
Yeah, absolutely agree. Those choices are extremely important. And we actually had a recent discussion with our myeloma colleagues here, and they were saying, well, you're becoming like myeloma. And partially we are, because we have choices, and that's a good thing to have. But partially we are not, because you've heard it here multiple times already. Fixed duration is really what we are frequently looking at in lymphoma, right? So we are trying to develop these new ways of looking at more of a fixed duration than our colleagues in myeloma, although they are also looking at MRD and some other strategies there as well. Marek?
I think that what is really very important is the evaluation CD19 expression, because it's, at least here in the Europe, Czech Republic, it's sometimes required by the insurance company just to prove that the patient is still CD19 positive, which is not very reasonable, because there are the different antibodies and different situations. So I think that this is something we have to be aware, that sometimes the CD19 expression using different antibodies doesn't reflect the real situations.
Do you currently assess CD19 expression prior to tafasitamab treatment in your practice?
Yeah, actually we do, but not because of the, let's say, the insurance issues. And it's quite interesting that mainly for the antibody drug conjugates, it doesn't seem it plays any role. So for the CD19 or for this anti-CD30, yeah.
Well, thank you. I think we are coming to a time here, but to summarize, tafasitamab and other CD19 antibodies appear to be very attractive therapy and CD19 is an important target, increasingly important with the cellular therapies in this space as well. The sequencing and persistence of CD19 is something which is an issue, and we need to understand this better, as you pointed out. And there is a frontline study ongoing, so eagerly awaiting those results. How the doublet will compare to R-CHOP, right? So thanks again. This was a great discussion. Gilles, any other comments from you?
No, I don't. I think it's an interesting evolving landscape, as Mike said. I think one of the differences, although one of my colleagues claimed the opposite yesterday in a meeting, is that in DLBCL we aim to cure patients, and that's a little bit different from the myeloma landscape. But maybe our colleague with myeloma will have some success in this field.